Welcome to the Innovation Accelerator podcast, brought to you by Innovacer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovacer, everyone works in the service of patients like never before as one. Visit us online at innovacer.com.
Hello, everyone, and welcome back to the Innovation Accelerator podcast. I'm Steve Ambrose, Director of Content Marketing for Innovacer, and today we'll be talking about opportunity through the prism of innovation, decisions, and data with Dr. Glenn Steele. Dr. Steele serves as the chairman of GSteele Health Solutions, an independently operated venture launched to help healthcare organizations create value and improve quality. He's the former president and chief executive officer of Geisinger Health System, an integrated health services organization nationally recognized for its innovative use of the electronic health record and the development and implementation of innovative care models. In addition, Dr. Steele serves as chairman of City of Hope. He joined the City of Hope Board of Directors and is on Access Hope, a subsidiary of City of Hope dedicated to serving employers and their healthcare partners by providing access to City of Hope's exceptional cancer expertise. He's been named consecutive times to Modern Healthcare's 50 most powerful physician executives in healthcare, Modern Healthcare's 100 most powerful people in healthcare, and Becker's 100 nonprofit hospital health system CEOs to know. In addition, Dr. Steele served on the National Academy of Medicine's Vital Directions for Health and Healthcare Initiative, a select group providing expert guidance in 19 priority focus areas for U.S. health policy. Dr. Steele, I want to welcome you to the show. It is great to have you with us.
Good morning, Steve. Good to be with you.
I'll just jump right in and start with the questions. In many ways, we know that COVID has tore a Band-Aid off our current health system to expose a lot of functional weaknesses and limitations, poor alignment of incentives, like mass unaffordability, health inequity. So at this time, where are the most critically important areas for health provider leaders to be making investments into, and why?
Well, I think the predicate for what you say has to do with the lack of public health capability. And that's kind of in the context of a huge lack of trust that people have when they're listening to our leaders, whether they're political leaders or healthcare leaders. And most of the health services that we provide have to pick up the pieces from that lack of trust and lack of public health infrastructure. So I think the hospital situation is the most critical situation. With the various surges that we've had, and the capacity constraints then lead immediately to the employee burnout situation, and the response to that has been logical. A huge amount of caregiving that normally happens has been either postponed or has been kind of relocated. There's been a tremendous increase in virtual care. There's been, I think, a regulatory response that's been reasonable to allow a business model to be built around telehealth. Without a viable business model, you don't get the kind of switch from physical to virtual. So there are a lot of things that have happened. Supply chain. I mean, we've suddenly started to realize that our supply chain is fragile in many areas, including pharmacy. So I think there are reasonable responses. My optimistic view of this is that many of those responses will continue and will lead to fundamental change in how we deliver care and how we get care.
Dr. Steele, we spoke off air about hesitancy in leadership, and that is when decision makers may be thinking more about their job and future as opposed to the upside to empower meaningful change. And I wanted to ask you, as a former CEO at Geisinger and a leader who's constantly ranked in the top 50 leaders and thinkers across healthcare. I'd like you to share your thoughts about hesitancy in leadership, not only in how it impacts business, but more importantly, how it really impacts patient communities.
Well, I think a perfect concrete example of what you say, Steve, is the hospital centricity of most of our integrated delivery networks. And if your CFO for your network has been consistently winning in terms of hospital-based volume, hospital-based intervention, whether it's diagnostic or therapeutic, and that's where your margin comes from. If you're trying to attack that, by doing value-based care, if you're trying to do shared risk, if you're trying to figure out how to take responsibility for a population of patients, regardless of whether they're coming through the big house and getting interventions or not, there's a natural resistance to that. So that's a perfect example of the inertia. And it's not that the CFOs are dumb. It's not that it's just that they've been winning in a certain fashion for a long period of time. And when you try to move away from that, hospital margin based on fee-for-service volume, it's tough. And there are various ways of changing that behavior, but it's not easy.
Yeah, that's for sure. Today, one of the biggest shifts that we're seeing in healthcare is consumerism. And, we've talked about this off air. Healthcare consumers, the way that, I look at it anyway, is they're not just patients, but consumers also include self-insured employers. And according to a 2020 Kaiser Family Survey, self-insured employers now constitute 2/3 of all employers in our country. So I'd like to ask, how do you see the strengthening of the patient longitudinal record, a more 360-degree view of the patient, as significant in helping the nation's self-insured employers, around their costs as well as the health of their employees?
Well, activated consumers are really a key change in a huge number of our healthcare provision, but outside of healthcare provision as well. The key, and the more activated the consumers are, the more the relationship has to change between the healthcare providers and the customers, whether they're actual patients with chronic disease or acute problems, or whether they're just regular human beings who want to stay healthy as long as they possibly can. So all of that concept is good. The issue is when you get the information out to the consumers, and I think, we have no technical limitations to that now, but when you get the information out to the consumers, whether they're a part of a self-insured employer, or whether they're just a commercial payer customer, they have to know that the information that they're getting is reasonable. Now, the first thing is you give them the information about their own situation. So they have to have access to their own personal health record. That's critical. And there's no reason that should not happen. But the second thing is there's got to be some sort of a trusted relationship between a healthcare provider, whether it's a doc or whether it's a nurse or whether it's some other community-based individual, and the information that's delivered to the patient or to the consumer. Because otherwise, you've got so much information overload, and the question is, how much of that information is legitimate and how much of it is not? And we certainly don't want to develop in healthcare what seems to have been happening in terms of the political information that's out there and the misinformation. So I think it's number one, mandatory for all consumers to have access to their own healthcare information. Number two, all the other information that's available through the internet now has to be linked to a longitudinal, long-term trusted relationship with a human being so that the consumer can sort through what's really good information and what's misinformation.
Yes, and I wanted just to kind of go to the next question here that just connects right in, but staying on better data, how do you see direct contracting evolving? Connecting with self-insured employers directly to the provider organization side. I'd love to see how what your thoughts are on that, and in moving forward, if you're going to see a lot more growth in those areas.
I think you are, and that's already happened in certain areas. For instance, in the pharma supply chain, there's now much more direct contracting between the self-insured companies and PBMs that are delivering value-based pharma, particularly in the specialty drug area, which is very effective but very, very costly. The issue in healthcare services, other than pharma, is much more complex because you can't necessarily have a national solution for everything. If somebody's got diabetes and is an employee of your company and they need to have a vascular surgeon, they're going to see a vascular surgeon in a local market. And so the key there is to figure out how to be able to guide the employee with that need to the most efficient, value-based and accessible vascular surgeon in a given market. So it can't just be a simple across the nation solution. It's got to be an ability to scale, but it's also got to link to the market-based specialists or subspecialists, but it's got to link in a way that prioritizes those who are really giving good service and good value and good access, versus those who are not. And so that's the challenge. It can be done, but it's a little bit more complex.
Dr. Steele, that is, really insightful. And it brings up a side question for me about centers of excellence and self-insured employers, and then maybe even tying in what's going on in price transparency. And I'd like to get your thought on maybe this statement that price transparency and everything that's been happening with it ultimately is probably going to be more strongly driven and more taken advantage of by really savvy self-insured organizations that understand care and cost for their employers, as opposed to the individuals doing the shopping themselves. Do you see it that way, or how do you see that?
Well, I'll tell you, I think that the self-insured employers are extraordinarily interested in value, and value is not just cost; it's cost and quality, and so they're basically doing this because most good self-insured employers want to have healthy employees, and they want to have healthy employees over a period of time because they're going to be much more productive. The company will succeed generally based on the employees, and so their ability to filter a lot of the information and decide what's good information and what's bad information is really important, and that's a value add. Now you have to be careful about that because if you come across as too paternalistic, the employees will start to mistrust
Right.
the employer. That's right. So there's got to be employee buy-in in terms of prioritizing which of the services that are market based are good and which are not. And God knows you can't mandate things. Anytime you mandate something in this country, you're behind the eight ball,
Right.
just to start with. So it's got to be designed so that there's information showing which vascular surgeon or which vascular surgeons have a really good track record in terms of access, in terms of doing the right thing at the right time, for the right reason. And which don't, and then you've got to let your employees decide which of those to choose from in a given network. So I think, I think, and if it's, and there's a certain amount of care that's given out there that I think is commoditizable. I mean, if you, if you're thinking about, mammography, for instance, for your employees, if you're thinking about screening colonoscopy, if you're thinking about a number of things that are out there, there should be quality standards that are uniform and are kind of an expected for all of those. And for that, then what you look at is price. And as you are aware, and as most of us are aware, there's a huge price differential. And if you're in a cosmopolitan area where you've got a number of different providers, and you've got this kind of commoditized product that you can assume, or you can actually vet for having credible quality standards, then you just look at price. And you basically then can incent your employees to go to the lower price place because you've already vetted for quality. But that's, that probably represents a minority of the stuff that we're dealing with in terms of healthcare provision. I mean, most of it goes beyond, simply commodity. And then it becomes a little bit more difficult, but I think the relationship between the employer with the best interest long-term in their employees, plus the information that's delivered to the employee, will allow for some prioritization of choice in specialty and subspecialty based on value, not just cost, but cost plus quality.
Let's talk about innovative models and collaborative relationships. One area where you've committed both your background in cancer research and care, plus your innovative thinking, Dr. Steele, is Access Hope. Tell us a bit about this cutting edge program, if you could, and some of its unique benefits.
Yeah, well, we decided at City of Hope that that we wanted to democratize cancer care, and the definition of that was to try to reach out beyond our primary and secondary service area, which is in Southern California, and to create a structure that would allow us selling basically through large self-insured employers, allow us to improve what is a really remarkably suboptimal set of data on diagnosis of cancer. I mean, if you look at prevalent cancers across the country, and you look at optimal diagnosis at presentation, you're probably only optimal about 60% of the time.
Wow.
60 to 70% of the time. So that means, and it's not, it's not that the oncologist or the primary care people or what have you are ignorant, or it's not that they're irresponsible. It's just that there's so many dynamic changes, and almost all the diagnostic criteria, and certainly the therapeutics available for prevalent cancers. I mean, almost every prevalent cancer has 3 or 4 major improvements in either diagnosis or therapy every month if you scan the literature. Oh. And how any human being, as responsible as they possibly could be, as intelligent as they are, could keep up with that is just impossible. So what we decided we would do is to create a network of really well-branded, excellent centers of excellence in cancer care, and to use a series of subject matter experts and information technology to get our expertise out into the local markets where the companies that we were selling to had employees, essentially. And I think the unique aspect, Steve, of this is that we're not trying to replace the local market-based oncologists. We're actually trying to partner with them. And it's both for prevalent cancers that people are seeing and dealing with every day, but it's also for the very unusual, very tough kinds of cancers, where people would die if they weren't somehow connected to a center of excellence. So it's both of those cohorts. And
That's
it's, it's working out really well. I mean, we now have not only City of Hope, but we have Northwestern Memorial Cancer Center. We've got Dana-Farber Cancer Center. We've got the Winship in Atlanta associated with Emory. And we're actually in discussions with a couple of other foundational members. So it's not just us at City of Hope that's, trying to butter our own bread. It's a group of really well-branded experts that can partner with local market-based oncologists to the benefit of the employees of the companies that we're selling to.
so interesting. I mean, it really it ties in a bit with consumerism, but consumerism really from the end of first accomplishing better care and outcomes for the patient, obviously, where there's real gaps, it sounds like, but just going out there and recognizing that there are needs to be filled, and just, City of Hope through this program is just proactively just sort of the tip of the spear with this, right?
Yeah, well, we have two strategic engines here for getting us and getting our expertise and getting our brand outside of Southern California. One is Access Hope, and the other, of course, is the recent purchase of 3 of the residual remaining markets of Cancer Treatment Centers of America. So that takes us into Greater Atlanta, it takes us into Greater Chicago, and it takes us into the Phoenix market. All really, really good markets. And again, what we plan to do is to go in there and partner with local brands that are there, and try to bring our expertise, particularly in areas that are very tough areas. Brain cancer is a good example. A lot of the acute leukemias that are also kind of cohabitating with other chronic diseases, particularly in adults. A lot of the stuff that we do with CAR T cells and with bifunctional CAR T cells and other cellular therapies and gene therapy is just not available to the local market-based oncologist. And that's taking the stuff out to where the patients are, and partnering with good brands that are in the area. That's our definition of democratizing cancer care. And that's just one cohort. And cancer in the demography of the self-insured companies is not, that's not the highest prevalence disease that they're dealing with. But I can guarantee you, and the math is pretty obvious, when employees have cancer, the cost that represents for those companies is huge. It's huge. And it's not just financial cost. It's employee productivity, it's family issues. I mean, there's a huge ripple effect from the time you're diagnosed with a cancer. No question about it.
Let's switch to how change is happening through mergers and acquisitions in health systems. So a recent Kaufman Hall report showed that 49 transactions were announced by hospitals and health systems last year. So that's down in pace by about 50% in years past. But the size of the smaller party involvement was up from 388 million to almost 620 million on average. If we go back to the 80s and 90s, Dr. Steele, M&As were all about containing costs, and now they're more about taking advantage of shifting from inpatient to outpatient. But today, what areas do you see as the primary drivers in mergers and acquisitions in hospitals and health systems?
Well, the primary driver is fear. and whenever there's fear, there's always a tendency, and obviously the COVID, you and I talked about this earlier, but the COVID context has really created huge stresses, particularly for the hospital-centric integrated delivery networks. And a response to that is to get bigger and merge. The other thing is that as we go from fee-for-service to value-based care, the margins that we have been used to in terms of the hospital-based interventions are not there, or they're not proven to be there. So again, all of these folks who are leading the IDNs, one of their strategic responses is to get bigger. And that, that the obvious advantage to that is the balance sheet is improved. And when the balance sheet is improved, there's more wiggle room. There's more puts and takes, basically. Your ability to go to the market for liquidity increases, essentially. And the real question is whether that all ends up creating more value for the people who are served, in the communities that are aggregated, or not. And as you're well aware, the literature on that is very ambiguous. I mean, you got the AHA basically, who are essentially representing the IDNs, putting out papers that say that there is, in fact, a value outcome, a value increase from a lot of these mergers and acquisitions. And then you've got, people from the Harvard School of Public Health and other very credible places that are claiming that the narrative that justifies the mergers, which is we're going to bring, better care at lower cost, is a narrative that has not proven out for a lot of the horizontal M&A. Now, the vertical M&A is totally different, Steve. And the vertical M&A, I think, is really potentially innovative. It's not easy to transact. And a good example of the vertical M&A, obviously, would be the Aetna-CVS merger. And again, you're taking the capabilities of a payer, a very large, very successful payer, and you're taking the capabilities of a vast network of physical sites, that used to, push pills and are now, doing not only pharmaceutical stuff, but are trying to become, a touch point for primary care. And again, that's not easy to transact because you've got, different business models, you've got different cultures, but it is a very interesting potential innovation. And it's, and again, that's there are many examples of vertical M&A, which I think are pretty interesting.
It is interesting because even though we're looking in value-based care to ideally move away from transactional volume and more into the genuine value of the care itself, it still seems that a lot of the strategy on these mergers and acquisitions, whether they're horizontal and certainly vertical, are still a lot about volume. Even though the margins are going to get smaller, you're simply trying to, as I see it anyway, let me know how you feel about this, but seems like that it's about getting more people under your umbrella and then engaging them in more touch points along their journey.
You're absolutely right. And a collateral benefit, obviously, is if you're doing a big horizontal M&A, your network, I mean, you're absolutely critical to the payer network. So, it gives you more leverage when you're, negotiating price per unit,
Yeah.
which is still the dominant, it's still the dominant reimbursement dynamic that's out there. I mean, obviously the public payer has been moving to VBC for quite a while. Managed care, through particularly the Medicaid MCOs, are moving to VBC. More and more of the commercial payers are at least talking about using their networks in ways that push towards VBC. But again, you and I know that the dominant reimbursement dynamic is still based on old-fashioned fee-for-service and price per unit.
So a big challenge and opportunity exists in the area of medication adherence. A widespread challenge, as we know, that's responsible for up to $300 billion each year in costs, 10% of hospitalizations, and the estimates are close to 125,000 unnecessary deaths every single year. So, Dr. Steele, how do you see provider organizations and really the pharmaceutical industry better collaborating and forming partnering relationships to impact this issue of adherence, as well as collaborating on other key challenges in patient care and outcomes?
Well, listen, a great example of that, concrete example, was our relationship when I was at Geisinger with Merck and with AstraZeneca. And the Merck relationship was a really perfect incentive to try to get the 50% of patients who either didn't understand what our docs and our nurse practitioners said when they recommended a certain drug, or didn't agree, but didn't tell the doc that they didn't agree, or didn't have the money to pay for the prescription, once the patient left the doctor's office. I mean, 50%, isn't that incredible? And
Yeah.
and we decided we'd do a series of experiments between Geisinger and Merck to see how we could increase that, increase the efficiency of the patient's knowledge base and understanding, and then also mitigate some of the financial issues that would lead to saying yes when you were in front of the doc, but not going to the pharmacy and getting your drugs. And what we found, I mean, it was particularly when you look at hypertension and when you look at diabetes, two of the most prevalent chronic diseases we were dealing with. What you found was that over a period of time, your costs for a population of diabetics or hypertensive patients went up in terms of the pharmacy, but you vastly captured the value by decreasing the number of emergency room visits, or emergency room visits followed by inpatient admissions. And that took us less than a year to get a return that was about a 3x. I mean, It was incredible. And those are perfect examples of, and it's, it's very granular, it's very detailed. You've got to understand the nitty-gritty of why patients say yes when they talk to the doc or the nurse practitioner, and then don't go ahead and get their medications. And that, the diabetes and the hypertension were just, they were just kind of individual examples, but it could be across the board. So I think the combination, and we were really advantaged when I was at Geisinger because we had a payer as well as a very large provider in the same fiduciary. So we knew for about 50% of our patients, not only everything about the provision of care for them, but we also understood on the payer side, where our insurance company was responsible for them, the financial implications. So we had the perfect ability to look at that patient population over time, both in terms of healthcare outcome and healthcare costs. And that could be done even if you don't have that all in the same fiduciary, but it demands an infrastructure of information technology that we at Innovacer are capable of actually providing. That's one of our goals at Innovacer, to be able to provide that technology across different compartments, even when those compartments are not in the same fiduciary.
Right, absolutely. Well, Dr. Steele, it has been a privilege and a pleasure speaking with you, and I look forward to doing it again really soon. Thank you so much for coming on today.
Steve, it's my pleasure. Thank you.
Our thanks to Dr. Glenn Steele for taking his time to chat with us today about opportunities through the prism of innovation, decisions, and data. For our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovacer podcast for more shows covering the healthcare IT topics that you care about.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovacer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovacer Health Cloud. For more information, please visit innovacer.com.